Okay, welcome everybody to the Health Overview and Scrutiny Committee. Most of you should know me by now. I'm Ewan Walters. I'm a Senior Democratic Services Officer. Can I just remind you all that this meeting is broadcast live via the County Council's website and will be available for viewing after the meeting. So could everybody please switch their microphone on when speaking and then turn off when finished speaking? Okay. So this is the first meeting of the Health Overview and Scrutiny Committee after the election and the annual meeting of the County Council. So that means the first item on the agenda is appointment of chairman. And Mr. Lee Brecken was nominated as chairman at the annual meeting on the 17th of May 2017. So can I have any nominations for chairman? Do we have anybody propose Mr. Brecken as chair? Thank you very much. And a seconder as well? Yeah, thank you. Okay. Mr. Brecken, I announce you're appointed as chair for the 2017-18 year, and I'll hand over to you.
Okay, thank you, Ian. Can I welcome again members? I think it's the first meeting that we are all new members here, except for Dr. Hill, who was obviously on the previous overview panel. It might just be interesting just to make sure we know how the microphones work, that we just get members to introduce themselves and also the officers as well. So if I start with, we've obviously had Ewan's introduction, so I go to Rosemary.
I'm Rosemary Palmer, Democratic Services Manager.
I'm Rick Moore, I'm Chairman of Health Watch.
Sarah Hill, County Councillor, Market Harbour East Division.
Dean Gamble, County Councillor, Oadby.
Ted Parton, new member for Loughborough South.
Amanda Hack, County Councillor for Braunston.
Louise Richardson, County Councillor for Enderby and Lubbersthorpe.
Peter Bedford, County Councillor for Markfield, Desford and Thornton.
Hilary Fryer, a new member, County Councillor for Quorn and Barrow-upon-Soar.
Deborah Taylor, County Councillor for the Bradgate Division.
Okay, thank you to members and officers. We obviously have speakers this afternoon and they'll be introduced as they come to their item on the agenda. Moving on to the agenda, item 2, election of Deputy Chairman. Could I now invite nominations for a Vice Chairman?
Mr. Chairman, I'd like to nominate Mrs. Deborah Taylor.
Thank you. Do I have a seconder?
Mr. Chairman, I would like to second that nomination, please.
Okay, thank you. So we have proposed and seconder. Members in favour, show of hands. Thank you. So congratulations to Deborah on becoming Deputy Chairman. Item 3 is the minutes of the meeting held on the 1st of March 2017. I propose that the minutes of the meetings held on the 1st of March 2017 are taken and read, confirmed and signed. Could I have a show of hands for agreement? Okay, thank you. Agenda item 4, question time. I have not received any questions for this committee.
Agenda Mr. Chairman, just ask a question for clarification. Obviously, being a new member, what does this actually mean then, question time?
This is for questions of members of the public. Members of the public are entitled to write to this committee and ask questions through this forum, but we haven't had any questions for this meeting. Okay, thank you. Agenda item 5 is questions asked by members under Standing Orders 7.3 and 7.5. Again, I have not received any questions from members for this committee. Agenda item 6, to advise of any other items which the Chairman has decided to take as urgent elsewhere on the agenda. I have not been told of any urgent items. However, I have agreed to vary the order of business and I'm going to take item 13 after item 10 to enable Tim Sachs to attend another meeting later on this afternoon. Agenda item 7, declarations of interest in respect of items on this agenda. Do any members have any interest they wish to declare? Yes.
Thank you, Mr. Chairman. Just so people are aware, my daughter works for the General Medical Council and there is the GP 5-year forward, which might conflict that, but no other interest, thank you.
No other interests? Thank you. Agenda item 8, declarations of the party whip in accordance with Overview and Scrutiny Procedure Rule 16. Do any members have any declarations? No, thank you. Item 9, presentation of petitions under Standing Order 36. Again, we have no petitions received for today's committee. So we'll now move on to agenda item 10, integrated locality teams, which is on pages 13 to 44 of your agenda pack. And can I welcome Cheryl Davenport, Director of Health and Care Integration, to introduce this item. Thank you. Can I say, as per the slide, I'll introduce Louise Young as well. Thank you.
Good afternoon, everyone. The presentation today is about a piece of work that's been running for a number of months in the local health economy, and it's linked to the work on the Sustainability and Transformation Plan. Now, we have a presentation later on the agenda about the STP, the Sustainability and Transformation Plan, but I have included a couple of introductory slides to set the context for this presentation. If it's acceptable to the committee, is it okay if I stand so I can see the slides and take you through them? Thank you. Okay, hopefully that's okay from a sound point of view. Just touching then on the Sustainability and Transformation Plan briefly, and the slides provide some links for you to key documents. This is a place-based plan for transforming health and care, and it covers the whole of Leicester, Leicestershire and Rutland. There is a case for change which was set out in our Better Care Together strategy, which preceded the STP, but the two are now in one document and actually set out the 5-year plan for the future. Again, I'll let Toby cover this in more detail later. But one of the key issues for us is the rise in the older number of our population over the next few years, and the long-term illnesses and the issues that will present in our local population. The demands that this will place on the health and care system means that we just can't carry on as we are. We need to transform and do things differently. If you look at the financial gap in terms of the demands on the local system, this is a significant gap, and without making transformational change, we will not be able to meet this gap. So there is an up to a £400 million gap in our collective finances across health and care if we simply stay as we are. There is a very large amount of money spent already on health and care services locally, so it's about how we best apply the existing funds to the future models of care that we need to put into place. So this is not about cuts, it's about choices. It's about how we actually design new models of care that are more effective and meet the needs of our population in a different way. So there are 3 areas within the STP that we're asked to look at: health and well-being, care and quality, and finance and efficiency. Again, I won't go through all of these, but in terms of the work that we're doing in integrated locality teams, we're looking at all 3 aspects of this, the triple aim of the STP. So there's an overall philosophy for the STP which is about home first. This means that it is much better to plan care outside of hospital and only attend hospital when absolutely necessary. So we're asking ourselves as professionals, as managers, as the public, why are we not at home, and how best can we be kept at home or in the community for the majority of our care. So the priorities in the STP include new models of care, planning where services should take place on the facilities that we've got and how those should be configured, the redesign of care pathways, so an example might be the redesign of end of life, which is currently going on, and the operational efficiencies and the enablers that we would need in place to operate as a more effective health and care system. So these 5 areas you will see in the STP, and the new models of care, number 1, is where the work on integrated locality teams and home first is in particular taking place. And you'll also hear later in the agenda today about the work on the GP redesign, which is also linked to new models of care. The way that we've been looking at how we might work differently in the community relates to this slide. We see on the left the patient managing their own condition, actually thinking about how they prevent ill health or maintain their health and well-being, and what they can do for themselves and with the assets that they might have in their community, within their family, and all of the preventative offer that is available in the Leicestershire area. We then have the GP as the central coordinating place for the majority of somebody's care needs. And it's really important that the GP is at the centre of coordinating care for people who have long-term conditions particularly. Then as we move across the slide, we have opportunities for GP practices to work more together in federations. By doing that, they can offer a broader base of services than they might on their own. And then we start to look at the integrated ways of working, not just the NHS, but how do we work with social care? How do we work with different professions in the community? How do we use all the facilities and professional skills that are available in our local area? And then ultimately, if you need urgent medical attention or you need specialist care, then the hospital might be the place where you are receiving that care. So the change that we're trying to introduce really focuses on this community side of the work. And there are 4 aspects to that: increasing prevention and self-management, developing accessible and responsive primary and community care. This is really important because if we want the public to have confidence and rely on services that are in their local community, we want them to use those and feel that those are the first port of call, not necessarily going to the A&E department. This means developing extended primary and community care teams so that the skills that are needed, the professional support is on hand in the community setting. And it also means bringing some of the specialist care out of the hospital to work side by side with other professions. So there are some aspects of outpatient work and diagnostic work that could be done more in the community if we designed it in that way. So we've put in place a piece of work called the Integrated Teams Programme. And you'll see at the top of this chart, we've got the system leadership team. That's the team that's looking at the whole of the STP, and we're just one programme within it. So we have a programme board that's running this particular element of the STP. And within that, we've got a number of groups that we're working with. On the left-hand side, you can see that we've got a group that's responsible for implementing integrated locality teams in West Leicestershire, one in East Leicestershire and one in the city, because this is an LLR-wide development. So each of the clinical commissioning groups is leading implementation in their area. And then you can see on the right, we've got some other areas of work that are very much part of our programme, End of Life, that I mentioned earlier, where there was an existing piece of work going on to redesign end-of-life care. That's been adopted into our programme. We've also got the cardiorespiratory service, where they've been doing some redesign already. That's been adopted into our programme, and also the falls prevention and falls delivery groups that have also been adopted into our programme. And finally, we're doing some work on organisational development because we want to upskill our workforce so that they can operate in a new way. So integrated locality teams initially will be working with particular parts of the population, and the 3 groups that we've identified who would benefit from this way of working are these 3 here. So adults with 5 or more chronic conditions, people who have a frailty marker, which may be to do with their age but may be to do with other conditions, and people who we can predict their costs of care, particularly secondary care, over the next 12 months will be high. And if we think about those groups of people, those are the ones that we feel would benefit from more coordinated care in the community. And we're testing this way of working with these groups of patients at the moment. And what we find from that will then determine what the final model will look like. So what we've asked the integrated locality teams to do is to look at the cohorts of people they have in their local population that fit in those categories, understand their needs and their data in a lot more depth, and crucially across organisations, not just taking a GP view, but taking the GP view plus the social services view plus the community nursing view. What holistically could be done to support this person better? We're also asking them to look at why care and support varies. We've had different models of care in the community develop over the last 10 years in Leicester, Leicestershire and Rutland. Not all the same. Why is that? What's more effective? What might we want to adopt across the piece? And then we want to define some new ways of working, test the new ways of working, and then plan how we might implement that once we've learned from the testing areas that we've got currently underway. This slide attempts to show pictorially what we mean by an integrated locality team. So in the middle you've got the GP, the practice nurse, the social care services, the local pharmacist, and what we're expecting to see wrap around them in terms of the offer on the ground. And we're looking at better coordination, improved access to specialist support, effective care planning, much more effective care planning, improving health and well-being, taking more control over long-term conditions, and reducing all the handoffs that go on between professionals, because actually everybody should be working together towards the same objectives. So this is the structure I mentioned earlier for West, East and City. We've got integrated teams that have been set up to lead, and then on the ground at this much more local level, we've got the actual operational people on the ground from their team, so individual social workers, nurses, etc., who are actually operating at the sub-locality level. And this slide shows you, and I think you've got this in a handout as well, the actual structure. So who are the practices that are aligned to the particular areas within those three CCGs? Which practices are in which sub-locality? So if you looking at your own local area, you can see where that fits. And here's one for East. So, for instance, here in the Melton and Rutland area, you've got about 101,000 population broken down into those two sub-localities. Market Harborough, similarly, broken down into localities. And for West Leicestershire, you can see here the large Hinckley and Bosworth area broken down into its practices. So just to update you on how this work is progressing, we are at the early stages of this work. There have been 14 sites up and down the country who last year were already selected by NHS England to be vanguards for this particular area of work. So one of those, for example, is Sunderland, and we've been looking at interest with the work that Sunderland have been doing. So we have taken learning from areas like Sunderland to think about how we might replicate their work here. We've already implemented the integrated locality teams in terms of the leadership that's needed for those. And we've identified key individuals who will actually take a leadership responsibility, including GPs, for implementing this. We've been working with district councils, looking at how the health and wellbeing forums that exist in district councils can interact with their local integrated locality teams, and we've been getting representation as well from district councils to join some of those teams, which is great. And we're now testing some new ways of working. And in your pack, I think you've been given the May bulletin for this area of work, which goes into a bit more detail about the test areas that we've been selecting. Those have literally just started. So again, you could have a look at those in terms of your local area. And a piece of work that I'm involved in very particularly is looking at how we measure the impact of integrated locality teams. The vanguards that I mentioned, including Sunderland and others, they've had opportunities to test certain ways of measuring integrated locality teams. Are they having an impact on emergency care? Are they having an impact on quality of care planning? These are the sorts of things that we want to measure as we roll this out. So there's a piece of work going on to establish that. And then the stakeholder bulletins that I mentioned, which you'd be able to receive routinely if you so wish. This is a slide about how the STP is being governed. It's really just to indicate that the Health and Wellbeing Board has a role, a very key role, in working on the STP. Each of the Health and Wellbeing Boards has been given a particular area to concentrate on, and the Leicestershire Health and Wellbeing Board has being given the area of integrated locality teams. So from a local perspective, we have a very keen eye on these developments and are receiving regular updates there. I think that's everything from me for today. I realise that was a lot of information, but I'm very happy to take questions. Thank you.
Okay, thank you for that, Cheryl. I will open it up to questions to members. Dr. Hill.
Thank you. I'm just going to get really picky, I'm sorry, but where he's got, and I'll use a local example because I know it, Market Harborough, he's got Market Harborough, Husbands Bosworth, Market Harborough. That's one medical centre. Underneath it says south east, Bilston, Two Shires and Kibworth. Two Shires has the surgery in Market Harborough. So Market Harborough isn't just, you know what I'm trying to say, you've done it on practices, and I really don't know where you get your squiggly lines on the map, because Great Glen is part of the Kibworth Two Shires Empire, or the Kibworth Empire, and it's the maps are drawn. And so that's one issue, is calling them in that way is not reflective of where people actually go to the doctors. And it suddenly struck me while I was listening to you, there are people on the very sort of southeastern corner between Market Harborough and Leicestershire and Rutland who actually their GP's in Corby. So how, you know, and my guess is there's other bits of the county where that applies. I mean, so how are they being dealt with? Are we going to integrate with what Northamptonshire are doing? So that's my 2 points, Chair.
Okay, so to deal with your last point first, this is about the patients who are registered with GPs in our CCG boundary, this model of care. However, because it is a national way of working that's being rolled out, it is probable, if not likely, that the majority of the areas on our boundaries are already starting to implement this if they're not already a vanguard. So there was one vanguard in Nottinghamshire, for example, for this area of work. So over the course of this year and next year, you would expect all areas of the country to be adopting pretty similar integrated locality teams approach. The boundary issues are difficult, particularly around the social services boundaries for local authorities. But I think it will be down to our team to think about any handoffs that might be needed between boundary areas, and to have a conversation in due course with those boundary areas about how their plans are progressing and whether our models are developing along similar lines. In terms of the harbour piece, I think that's something I probably need to take away and have a further look at. Market Harborough has been the area that has developed in the latter stages of this process. So if we've got any delineation problems there, we perhaps need to go back and look again. So thank you for flagging that up.
Councillor Hack, sorry.
There we go. Hi. I just wanted to ask a particular question about capacity. So in my community of Braunston, access to GP services is becoming particularly problematic. So I'm really concerned how this would work in that kind of environment.
Okay, so one of the rationales for this piece of work is that there's a proportion of GP workload which can be delivered jointly with other partners, and there's a proportion of GP workload that can be delivered in a preventative way that wouldn't involve necessarily a GP appointment. And I'm sure that Tim will cover this in more detail later. But the proposition is that by working with an integrated team, the GP can be supported so that activities and interventions that can be done on the behalf of the GP in the care plan that's set out across the partners by other professions are picked up by those other professions and delivered on their behalf, but that the GP is still accountable for the overall care plan and understands the care that's being delivered. I think it's really important as we go through this period of change in the STP that those workforce planning assumptions are really tested, and that's not just the workforce of the GPs themselves, but if we were setting out on this piece of work and weren't learning what this means for community nurses doing things differently, social care services doing things differently, and some of the prevention services doing things differently, all of that workforce capacity needs to be targeted to new ways of working. So we need to get the GP size of workforce right, but we need to get the other professions sized and doing the tasks that they are best to do. So I think there'll be a lot of learning from integrated locality teams and in some cases a bit of letting go of traditional ways of working so that others can pick up new models of care jointly. We do need to support our GPs in that, and that's why they are central to designing what this looks like.
Okay, thank you. Councillor Fryer.
I was just reading through earlier the report, the May bulletin, and under the summary care record, and the programme was being 3 phases, and it was hoped that the all System 1 practice training would be completed by the end of April, and the MIS practice training be completed by the mid-May of this year, and I just wondered if that is all on schedule and has been met.
Yes, that is on schedule. All practices have been trained on System 1. Sorry. Yes, it is in schedule. In fact, some elements are almost advanced in, so we're bringing in the social care element quicker than what was in the original plan. So we're sticking to the plan.
Thank you very much.
Councillor Parton.
Thank you. Please, Mo, I return to page 18, which is entitled Making Us Fit for Future Care. Thank you. What do we mean by the older population? Do we actually have? Are we talking? Is it to do with the box on the right where it talks about people aged 65 and over? Okay. And so the older population means people 65 and over. Yeah. Okay. So specifically, what's the specification for limited a little and limited a lot?
Yeah, I mean, I think that would be difficult to encapsulate, but I think we'd be talking about the difference between people who perhaps had difficulties with basic activities of daily living, such as moving about the house, washing, dressing, bathing, etc., versus somebody who maybe couldn't walk at all due to a severe respiratory condition or immobility. So the range of what we could be dealing with in terms of long-term conditions and how much people are impacted by that can vary from minimal impact on activities of daily living to very significant impact involving daily medical attention and support.
Okay, so will there be a prescribed list provided by hospitals or the GPs specifying who's in each category?
I think from the frailty marker and the long-term conditions that we are going to be identifying in the GP practice data, we would have a view of what those conditions would be. I don't think we'd be in a position today or imminently to say what that list would be per se, but the frailty marker particularly is something that's coming into place in July, and then we already have GP data categorised by long-term condition that patients have, and we're able to understand that data in some depth.
Okay. And then moving to page 23, in terms of the where we talk about changes and new ways of working. Are these new ways of working what is described later on in the report, or is this an aspiration at the moment, or are there specific tasks that are being evaluated and considered, and if so, perhaps you could, please would you be so kind as to give us some examples of what they are?
Yeah, this is really important actually. There are a list of interventions that professionals have suggested would be good interventions for anybody in the 3 cohorts of patients I mentioned to receive. So for example, you might ask yourself the question, have all the people who are frail, have 5 long-term conditions and have high care costs had their flu vaccination? Have all of them been offered information on some of the preventative services that might be available in the local health economy? Have all of them had their care plan reviewed on a regular basis, for example? Is there a plan of what they should do if their condition deteriorated? So the professionals involved in this work have been setting out those interventions that they feel would be most of benefit to that group of patients, and then we're going to be testing which ones of those have the most impact through the course of this work. So by the time we've completed our testing, we will have a view about which are the interventions that we feel should be offered to all of the patients in these groups on a routine basis. And what you'll see across LLR is that varies at the moment as to how those things are delivered, and we want to make that systematic and actually bring all those things forward for the future. So I hope that gives you a flavour of what we're doing.
So in regards to that, what is the previous? What is the current? What has been the talking about past, present, and future? What has been? Can we have access to see what the past programme was, what the present is, and how it differs? Because having been a carer for two elderly gentlemen over for a period of 17 years, but not since 2014, and having witnessed their care, a lot of what you've said would seem to have been in place for them in their lifetimes, and I'm trying to establish what exactly is changing that perhaps wasn't being put into practice in their lifetimes, even though, of course, well, one passed away in 2008, the other one passed away in 2014. 13, I apologise.
So we have had a system in place for about 5 years now where GPs have identified the top 2% of their practice that might be at risk of a hospital admission and offered more intensive case management to them. That's been done primarily by GPs using GP data, and perhaps the people that you're referring to benefited from that system in the past. What we're doing now is saying we don't just want to look at the top 2% from a GP perspective. We want to look at 3 particular groups of patients, the 3 that I outlined on the slide, who would benefit not just from GP support, but also from community nursing support and from social care interventions, and that jointly there would be a much more coordinated way of working with those people. That isn't to say that people in the past didn't receive social care support or community nursing support. They did, and that's been in place for a while. But working properly hand in hand, using the same data, working with the same people on the ground, and working towards that home first philosophy jointly is a different era of integrated working than where we've been before. I think we've had pieces of the jigsaw before, but now we're going to have the whole jigsaw is how I would describe it. And if you'd like information on what was delivered previously, we can certainly make that available.
I would appreciate that, Chair, if we may.
I was going to say, yeah, thank you for that. I think that would be useful. I think there were some good sort of specifics that you raised there, and I think it's probably information for all members, especially the new ones within Council. So,
yeah. May I just ask one final question, please, Chair?
Okay.
As part of my research for this meeting, I obviously started at the very basics by doing an internet search of better care together, and I obviously observed many plans from all over the country, and obviously I found the website for Leicester, Leicestershire and Rutland. On the website, it talks about, on the events page, it says a number of events have been held across the area in early 2017, and it talks about because of the general election there was a period of purdah. But I can't seem to get this website to show what future events there are. Could we update the website, or is it because there's no future events planned currently for consultation?
If I may, Chair, I think that's a question perhaps Toby can answer more fully under the STP item, if that's okay.
Yeah,
Okay.
that sounds good. All right.
Thank you very much for all the answers.
Thank you, Councillor Barton. Councillor Richardson.
Thank you. I may have missed it somewhere in all of this, but we're talking about testing to give us the idea of what to put forward. But is there any time on the testing?
Yeah, hi. We've got 12 test beds now approved, and they are into full implementation. Just starting to move into implementation now as the first iteration, and we're due to do an initial review of that in September. And then that will look, the outcome of that really is it tests for us to look at what's working well, where some of the barriers may be, and that will then look to inform the next iteration of how the test beds and new models are working will progress.
Okay, thank you. I was going to say I'll close questions on this particular item. I think it's a subject that will no doubt come back with further updates to this scrutiny committee. So can I thank both Cheryl and Ruiz for that presentation and answers to questions. Next item I have agreed to move. So it's item 13, the GP 5-year forward view implementation. And can I welcome Tim Sachs, Chief Operating Officer for East Midland, East Leicestershire and Rutland CCG, who's going to give us a presentation. So, welcome, Tim.
Thank you very much, Chair. Just to introduce myself, Tim Sachs, Chief Operating Officer of East Leicestershire and Rutland CCG, but also the lead for the General Practice 5-year forward view and General Practice lead across the STP for Leicester, Leicestershire and Rutland. Firstly, just an apology. I noticed within the papers that my covering paper hasn't been included with here, so I'm sorry that didn't come through for some reason. However, just a little bit of background on where we are. I previously brought the GP 5-year forward view document to this committee, which was a collaborative document between the 3 CCGs in Leicester, Leicestershire and Rutland. That has been marked. Our homework was marked by NHS England recently, and we came up very positively with the highest marking being green, and of the 9 areas, 5 of them green and 4 of them amber green, which actually marked as highest in the Central Midlands area. So positive that those people who have looked at it feel that it's in the right ballpark. However, I think the reason I've been asked to come today is to talk about what next. It's a relatively high-level document which has a huge number of areas and actions to be considered. If you don't mind, I won't go through the slides one by one. The point of putting it in there is to show a real draft implementation plan for where we are. However, I'll run through it, but obviously I'm very happy to take any specific questions on any of the points within there. So first, just to update you on where we are and what we're doing. If you were to read the original plan and the delivery plan, there are hundreds of actions in there. And unsurprisingly, really, general practice is a huge area. We have 139 practices of varying size with various estate, various funding, various workforce issues, and various delivery of service. So to have a one-size-fits-all, you can't recommission general practice. What we can do is work very closely with them to ensure that we have the best service we can for our patients. So really we've focused on 2 areas. The first one you'll see on here is the must-dos from NHS England, the areas that they are focusing on the strongest, and those are access, workforce, and particularly looking at clinical pharmacists and international recruitment, mental health workers and premises. And the final one that they're very interested in is the level of transformational funding that is being put into general practice to support practices to look at how they deliver care. Cheryl previously talked about new models of care, and I think there is a real focus on general practice to look at how that is possible. Locally, we've been looking far more at areas we know there are the greatest issues. One of those is workforce. We have a huge amount of data on where we are with our workforce. We know facts such as across Leicestershire and Rutland, we have 65% of all registered nurses are over the age of 55, which gives us a huge potential retirement time bomb. We also know that if you look at the number of GPs coming through the system, there are fewer coming through as partners, more as salary GPs or locums. And actually, in comparison to 10 years ago, far fewer people coming through from medical school into general practice, more going into hospital medicine. So we have the information. The key question now is how do we improve recruitment and retention in our area? But more to the point, for those staff who are already here, how do we make sure there's the appropriate training available to enable people to look after patients in maybe a different way, looking at new models, working more closely together? So focusing on those areas, the one bit that is a real enabler that our practices have asked us to look at are some of the contract models and key questions to enable them to start doing things differently. If you ask the question about whether practices want to work together, more and more the response we're getting is yes. It's already happening in some areas. We have federations, we have practices merging, we have super partnerships where partnerships across more than one practice come together. But even on the informal basis, it's how can we provide care for not just our patients, but groups of patients, so we can look at our workforce and make sure that we have a sustainability within our own care, within our own services, but also ensuring that there is a broader level of care being provided to patients. So the next stages really for us are moving forward on two elements. Firstly, trying to put this huge amount of information into a single vision. We're trying to put a plan on a page for general practice, which, to be honest, is very difficult with so many different variables. But this isn't something that we want to do alone. It's something we want to do broader. And one of your colleagues earlier asked about the next set of events that we were going to be doing in relation to the STP. And one of them specifically in relation to general practice will be working with patient groups, working with stakeholders, working with patients themselves and practices to really have a very clear understanding about how we deliver some of this. Because you'll see here, we've got down, this document has there's 14 key areas that we want to focus on, and that's just this year. Those are the areas we believe are absolutely necessary to enable us to be able to move forward by delivering those. But there are so many others. And if we are looking at maybe new models of healthcare, we know there are problems in existence, and the member for Braunston already mentioned that area, and we know there are huge problems. And these are really for individual CCGs to work through what they're doing with their practices. But the aim of all of this is to have a broader, sustainable general practice in Leicester, Leicestershire and Rutland. And we need to have the debate in public, and we need to work in partnership with patients, because a wholesale change, if that's the right thing to do, is not something that can just be put in place. It has to be worked together for people to absolutely understand what services are available for them. At that point, I will stop, because I'm sure, having read through the information, there's probably a number of questions people may want to ask specifically or generally, but I'm really happy to take any questions on where we are now.
Any questions, members? Yeah, Councillor Gamble.
Could I ask how many vacancies there are in GP services? Because in OB, most of the surgeries are really struggling to get GPs to go into their surgeries, and which causes tremendous backlog of patients trying to access the services. So it's no good having all these great plans if we haven't got the GPs there in the first place.
So in answer to your question, it's not as straightforward as how many vacancies there are. As you'll be aware, each individual practice can decide who they employ and the skill set of the people that they employ to deliver their contract. And there isn't a set number of GPs or nurses that you would have per 1,000 population, say. From the information that we've been given, we know that there are many practices who are struggling to have GPs, either because GPs are working as locums rather than partners, or they're working part-time because general practice is flexible for people as well. So ultimately, the actual number, we don't know. The question we've asked is, rather than how many vacancies you've got, is with the funding that comes into your practice, are you actively looking for a GP? And across the patch, the answer is quite a number. But if you ask the same question across the whole country, it would be pretty much identical. We have a shortfall in GPs coming through the system. And that is why in many cases people are not just looking at GPs to provide the services, but other health professionals. But I go back to my previous point about the retirement time bomb for registered nurses. We need to make sure that people are coming through the system as well. So it is a huge, huge issue. And one of the reasons for looking at new models of providing general practice is that with size often comes a level of sustainability that people can actually work more closely together. And if someone does go off sick, if someone does retire, then there's more people within the system working together to be able to support that. And in areas such as West Leicestershire with their federation, some areas that they are in their 4 federations, some of the things that they are looking at particularly is how do you cross-cover? So how does the federation take responsibility if there are gaps, and how can they in effect provide a kind of an umbrella to look after that? And it's something that we're exploring in all areas.
Councillor Parton.
I wanted to ask you 2 questions, please, about again about the doctor levels. The first one is that the government had recently announced that the number of training places was going to rise from 6,000 to 7,500. Is that sufficient, do you think, to cover the shortfall that you were talking about?
In answer to that question, we welcome as many training placements as there possibly can be. The question you've got, though, is that actually how do we make general practice a place that people want to come and work? At the moment, it used to be about 50-50 of people who were going through training who would go half hospital, half general practice. That number has dropped significantly. And if you look at it on a whole-time equivalent basis, as in people going part-time or as locums, it's even less than that. So there's 2 key questions. One, how do we get at least half of the people coming through into general practice? But even more, we welcome that. And there is a programme, for example, in Lincolnshire. They've been working on international recruitment, and there are 28 new GPs coming in from Europe. We're looking at doing exactly the same thing and seeing which practices, there's national funding for that, seeing which practices want to take on one of these GPs for a minimum 3-year period. Because actually it is quite an attractive proposition, because NHS England funds £36,000 per GP over that period to support them. Yeah. So it's making sure that we actually look at everywhere possible to bring GPs into the system.
And the second question was actually regarding international recruitment. What representations have been made to the national government regarding the negotiations for leaving the EU? With the immigration figures?
I wish I could answer that question. That's a little above my pay grade, I'm afraid. But what we do still have is people do want to come and work here because it is still an attractive place to come and work. What we're hoping, though, is that over the next number of months and years that there is, still, when it comes to the workforce perspective, a very flexible allowing of immigration for people who have those skills, because we do need it in this country.
Yeah. Thank you.
Okay, thank you. Dr. Hill.
Thank you. I think the issue around GP practices is to remember that GP practices are all little private businesses, and my impression from talking to people who work in them and other people who are involved in partnership type businesses, that there is a reluctance amongst younger people, whatever reason, to actually put the capital in and go for that sort of long-term investment in a business, because you can make more money or as much or the same amount of money doing other things without the risk. And I think there's an issue around GPs are the partners who actually own the businesses, putting their hands in their pockets and doing deals that would make it attractive to people. Because we have got quite a few doctors. I mean, I've seen it where the people who work for 6 months and then move on and do something else because they can do just as well elsewhere. So I think there was an issue there for the practices. I think federations will help, and this will help. My other point was capital. Where are we with capital, Tim? Because when the STP came out, we needed about 200 million quid to make it all happen. Now, not all of that's going into GPs, but there is an issue around premises and expansion and all the rest of it. So where are we with all of that?
I'll answer your questions in turn. The first one regarding partnership is quite an interesting one. More and more, just for those who aren't fully aware, GPs have, if in a partnership, often they own the building. And the NHS reimburses what's called notional rent, so the cost of running the building and the cost to deliver that service. More and more people don't want to necessarily own the premises, and there are third-party organisations who are taking them on, so they're not running them. And part of that is that a lot of partners they have at times profited from selling their stake in the business when they've retired or when they've moved on, but people don't want to buy in. And because of that, you end up with some practices where there are 10 partners, of which there are 2 property-owning partners who are coming up to retirement. So they're looking at options for that. And actually that is less attractive, people putting their own capital in. So more and more, that's why people look at being salaried partners. I think if there wasn't the capital buy-in, in some cases, more people would want to necessarily be partners, although the work that goes with that is very difficult. In relation to capital, it's a really interesting question. There is no shortage of capital, but there's a huge shortage of revenue. So I was approached the other day. We are looking, for example, there's been lots of conversations in Oadby recently about 3 of the practices who are in premises that could be improved, and wouldn't it be beneficial if they could come together into one premises, for example, and there is a site that apparently has become available, and there's conversations that are going on. Now I've got companies who want to build that for us contacting me constantly because a conversation was had in public, and they're saying capital's fine. But it's the fact that the current cost of running those 3 practices is probably about £60,000 a year, and under a new build it'd be £250,000 a year. So where does the £200,000 of revenue come when our uplifts are incredibly low, and we either spend that money on direct patient services or we spend that money on premises? It's a very, very hard conundrum that we have, is the capital revenue one, because there just isn't the revenue as we're all squeezed across the patch.
Thank you. Councillor Taylor.
Thank you. Just a quick question on mental health. On page 58, you've got there that 800 mental health therapists will be in primary care by March 2018. What sort of level will those mental health therapists be? And also, will they be based at hospitals or in doctor surgery locally, or where is that going to be spread around?
Firstly, that is a national figure. I wish it was a local figure. So that's 800 across all of the areas. So across our patch, that would be somewhere around 10 or 12 additional mental health workers. These are based within practice. This is either through IAPT, so access to psychological therapies. So they are based within practice. They do clinics within practice. They do see people there. So it's more pushing towards that element. So does that answer your question? We're hoping they come through the system. They are training up more people, and they do prove to be hugely beneficial from what we've seen.
And do we know what sort of... Because the message I get is when people need counselling and things like and support, that they need it there and then, not in 3 months' time. So is that going to bring the waiting list down for support for mental health?
There's a difference between IAPT and counselling. They're slightly different services. But as it stands, there is a range of waiting times, and part of that's dependent on whether the staff stay, sickness, maternity leave, with a kind of fluid workforce. So waiting times can range from less than a week to 8 or 10 weeks sometimes. So it is trying to make sure that we have that variability and doing things more across, going back to the joint working, having a workforce across localities or numbers of practices, so we can bring the waiting time down and have that resilience rather than individual practices.
Thank you. Councillor Fryer.
Thank you, Dr. Sachs. My question is referring to GPs, and I know one of the other problems they have is, and I don't know how it's being tackled at the moment, is missed appointments, mistreatments. In my own area, in Barrow-upon-Soar, the figures came out for a month earlier this year, and something in like our practice, over 200 appointments were never kept. And then that had a knock-on effect for hospital treatments that were never taken up. And I just wonder how the GPs and what anything we can do or can be done to highlight this fact. A, it's costing money, and B, it's extending the time waiting for people who genuinely need to see a GP. Our GPs are forming now that if you miss more than 1 or 2 appointments, they will strike you off or threaten to strike you off. I think this is a really serious problem, and it's disheartening for everybody else.
Firstly, can I thank you for the promotion? I'm not a doctor.
Oh, sorry.
I'm married to one and the son of one, but
well,
not personally one. So by proxy, I will count that. But in answer to your question, we do have a real problem with DNAs. And actually, there are many practices who look at things in a slightly different way of how they do their booking. Some do just book on the day rather than pre-bookable. And actually, that in some practices, that really does work. And patients very much like it as well. But also, one of the real investments from NHS England is in relation to online consulting. Now, that doesn't necessarily mean doing things by email, but it does mean actually different ways of either looking at appointments, treating people, being able to get information, because we live in a very different society from the old school of it being traditionally booked and people booked 3-4 weeks in advance and what have you. People demand something slightly different, so we need to adapt for it. But when you look at how many hundreds of appointments, I think it's across the country, it ranges in millions of appointments a year. General practice needs to adapt. By doing that, though, some people won't be happy because it won't be the traditional way of booking. So we have to kind of find a happy medium that everybody is happy. But I know there are threats sometimes of the 2 strikes and out. It is a huge waste of resources, and we do have to find a solution both by communicating with members of the public, but also by practices offering sometimes differing ways of booking and ensuring that people keep their appointments without it being too onerous.
Yeah, following up from that is my own practice. If they've got your mobile or email on record 24 hours, 48 hours before your appointment, they email or text you, so they don't forget.
And that's quite common, and it's something that quite a lot of practices do. And so there are varying ways of doing it, and I just think more and more we need to adapt, particularly using technology.
Thank you. Tim, you said you were going to pause it for questions. You've had some questions. So do you have more to give us?
I could wax lyrical all day. It's such a huge topic, and I'm sure there are so many specific ones. The really important thing with this is that it is a real journey, and it's a journey of change, and change often feels quite scary, not just for members of the public, but for practices themselves. I know our colleagues in West and City have done some engagement events with their practices to look at this, and in East Cheshire and Rutland we're doing an event tomorrow afternoon with our members to really talk about new ways of working. It is a change that people might find scary, but it's one, if we work together, it's the only way we're really going to find a long-term solution for general practice. So I would really involve and really welcome all of your involvement, both in your constituent areas and us working together, and happy to come back at any point, both to ask questions and to let you know how we're getting on.
Okay, thank you. Councillor Parton, is it a quick question before we move on to... All right, thank you.
It actually refers again to... a previous question I'd asked when you used the phrase new ways of working. So in terms of the new ways of working that you're talking about, how specific and can you be with the GPs and the practices regarding that? Do they know exactly what these new ways of working are?
Chair, that's not a short answer. But I will be as brief as I can. Can I just give you an example? At the moment, if you go to your practice, pretty much everything is provided there. It's done by your own practice, you're registered there. Pretty much all the services outside of a hospital setting are provided by one practice in one setting. There are lots of examples across the country whereby maybe groups of practices come together to have on-the-day access, where they combine, covering a population maybe of 30 or 40,000 people, where you know that if you need to be seen on the day, you can go to one individual practice, not the one you normally go to, and you'll be seen by a health professional from one of the 3 or 4 practices, but it will give you a greater chance of getting an appointment on the day to be seen, but it will be maybe by a different health professional, and it'll be a different way of doing things, because normally you know where to go, you know the system that works within your practice. So there are dozens of examples of that sort of thing happening in the country. Examples of providing additional services like minor surgery or contraception done not just in one practice but on behalf of a number, and there are examples of this already happening. But it's still one of the comments that Councillor Hill just brought back. People are still relatively individualised. They're used to doing things by themselves. So actually it's quite a big shift change to go from that to actually working with other practices. But locally we have got examples of that starting to happen.
Okay. Thank you for your answers. That's good. I think once again, Tim, it's an area that we'll welcome you back here for updates and probably measurement as well as to where we are. So thank you for your presentation. Thank you. Next on the agenda, we're moving back to item 11, which is a presentation from the East Midlands Ambulance Service Update. Can I welcome Will Legg, who is the Director of Strategy at EMAS. He's going to give us a presentation. He's accompanied by Mark Gregory, who is the General Manager for EMAS Leicester, Leicestershire and Rutland, and also Lee Brentnall, Ambulance Operations Manager. We also have Tamsin Hooton, who's the Director of Urgent and Emergency Care, Leicester, Leicestershire and Rutland, CCGs, and she's also here in case there's any questions that we want answering from a CCG perspective. So welcome to you all, and look forward to your presentation.
Sorting out the technology, I think, for a second.
Far away.
Thank you, Chair. What I was going to propose was if I understand it's been about 12 months since you've seen East Midlands Ambulance Service at your Health Overview and Scrutiny Committee. So I thought it'd be quite helpful if Mark gave you an update, first of all, just in terms of where we've made some improvements, specifically in Leicestershire. I can then go into the presentation which has been circulated to you around the new ambulance response programme, touch on demand and capacity, and also make reference to our recent CQC report as well. I think if we go through both parts of that and then ask for questions at the end, if that's acceptable, Chair. Thank you.
Yeah, thank you. And I think when I came to see you previously, it was just a little over 12 months ago. I'd not long joined the East Midlands Ambulance Service, so it was the start of the journey. So it's quite useful to be able to come and give you an update on where we are and what progress has taken place. And it's fair to say it's been a year where it's had its own individual challenges, but positive as they've been. I think one of the first things we started to do really when I came back into the East Midlands Ambulance Service was look at our resourcing and how we were resourcing. So we've completely remodelled the way that we're resourced now, so that we're looking at forecast activity, working with other health partners to try and understand some of the challenges that are going to be coming into and we're going to be facing across the health economy, and modelling our workforce around that. So we've got much greater flexibility across the resource deployment that we're putting out, and specifically as well around how we're using our relief and our bank staff. So it's something very low level, but quite impactful, really. We also looked at our workforce plan because it's okay to have some ideas around how we're going to recruit and how we're going to forecast our activity, but the need to put some resource in those vehicles. And when I say resource, I'm talking about people specifically. One of the key challenges we'd seen was around, and I think I used the term last time around, robbing Peter to pay Paul. So a lot of organisations across the county were recruiting paramedics in because they recognised the flexibility that they had in terms of their skills. What that did is then posed a specific challenge for us as an organisation in trying to meet the workforce plan and put crews out on the road, and that led to an inexperienced workforce with its own individual challenges. We've shored that up this year, so our attrition rate is down from 10% to 6%. So we've seen an improvement of 4%, and that's continuing to improve. A positive step forward. We're retaining the staff, we're developing the staff, and putting that additional education in that they need. Again, to meet the modern healthcare setting, so that we can deliver care close to home. Working with other partners, commissioners, working across the STPs to really try and drive forward a new way of working, new models of care, as we've already heard about this morning. And again, a huge positive for us. Our workforce plan, we're running minimal vacancies across Leicestershire now, and we've got a forecast plan for the next 12 months of where we're going. We have been and started to recruit European paramedics again, which has been a successful starting point for us. And again, noting the discussions around Brexit, and we've got some assurances around that, but we're just ironing those through as the negotiations take place. I think one of the biggest challenges over the last 12 months has been, in terms of sustaining and maintaining our performance, has been around UHL and Leicester Royal Infirmary. What's been the positive from that, though, has been the relationship that we've formed with UHL, and they always say that everything's based and formed on relationships, but it has improved. It is very positive, and if I use last month as a real example, the The new department, should I say, at the start of May caused a number of different challenges, teething problems mainly. But UHL have really changed the way that they operate, changed some of their processes. And the benefit that that's brought to us as an organisation, and comes in terms of reduced handover times, significantly reduced handover times. What that's therefore done then is released our resource to attend patients within the community. And our performance we had and are having, continue to have, the best run of performance that we've seen in a very, very long time. We are achieving national standard, albeit not contracted to deliver national standard, but we are delivering national standard for Red 1 performance. And this month we are currently sitting at around about 77% against a national standard of 75 for Red 1 patients. Our Red 2 performance sits currently at month to date for June of 65%, which is a massive improvement for us. When I joined EMAS, we were sitting around 55%, some months lower. So it's a notable improvement. And whilst they're just performance and percentages, actually, when we look at the percentile times, the core time it takes us to reach patients, we're taking huge chunks out of that. So the average over the last 12 months has been 30 seconds. But if we do a comparator April 16 to June, we've reduced Red 1 response by about 1.5 minutes. Red 2 sits somewhere close to 2.5 minutes. A19, the time it takes us to get an ambulance on scene, is significantly reduced as well. So I think it's important to note the steps forward that we've taken. There are changes coming, as Will's going to touch on shortly, that will again assist and move us to a different place. But I wanted to just come and felt it important to say, I gave you some assurances 12 months ago that we were going to start a journey and we were going to see improvements, and we have seen those improvements. It's a long journey, but we have seen those improvements. I'll hand over to Will.
Thank you, Mark. Thank you, Mark. Okay, so I'm going to give you a quick overview of the National Ambulance Response Programme, and it's called ARP for short. This is a national piece of work that's really setting the scene for ambulance services and setting a new direction for ambulance services, trying to allow for what you've heard from Cheryl earlier on in terms of the STPs and a lot of the care closer to home, home first approaches to be supported by the ambulance services, because as some of you will know, the ambulance service tends to work with patients and have 3 different outcomes from an ambulance perspective. Those are hear and treat, where we treat a patient over the phone, so they call for help and we're able to deal with their particular concerns over the phone. See and treat, which is where we physically see the patient, so we go out, we see the patient wherever they happen to be, and we're able to treat them in that particular place. And see, treat and convey, which is where we take a patient to a particular facility, and typically that's an emergency department. So what the Ambulance Response Programme is looking to do is to try to support more of the hear and treat and more of the see and treat activity. Because we're through the STP, because we're trying to treat more patients at home, trying to avoid that episode of in-hospital care if we can possibly help it by supporting that patient with more community services, actually the ambulance service has got a really large part to play in that process. What we don't want to see going forward in the ambulance service is an automatic conveyance into an ED because it's the best place for the patient. That's not necessarily going to be the case and isn't necessarily the case right now. So the National Ambulance Response Programme, there's a lot of information about it on the NHS England website in particular, but it is very new to us as services. I'm really pleased to announce that we've been invited to be part of the pilot programme for the Ambulance Response Programme nationally. Although that notification has been really recent to us, we're just working through the detail of that right now in terms of what that means. Unfortunately, I can't give you a load of statistics today and a load of information today in terms of what that means to Leicestershire because it's so new to us, but I'm more than happy to do that at a future Health Overview and Scrutiny Committee, and we're also hoping to release some information over the next week or so around what that means to EMAS and to the patients. Just thinking through these slides, as you can see on the one that's on the screen at the moment, this particular one on the left-hand side obviously talks about the patient needs. So clearly, as it says on the screen there, they need the right type of response from EMAS with the right skills on board and also in the right time frame. Now that's really key because the current constitutional standards which we have to adhere to, and as Mark was talking about, the Red 1 and the Red 2 standards, those are targets for us to meet within a particular time frame, a certain percentage of patients, which drives a certain type of response model from an ambulance service, and every ambulance service across the country is the same. So a Red 2 patient we have to see in 8 minutes, 75% of patients in 8 minutes, which in a lot of cases means that we send a car first and then we send an ambulance afterwards, because that's the quickest way to get to that patient within 8 minutes. With the future ambulance response programme, the changes that they're looking to put in place means that we're able to send the right vehicle to that patient the first time. And what that means is if you've got a patient which is obviously going to be going to a conveyance, so if they're obviously going to be going to hospital, what it's going to mean is that we can send the ambulance first, so what we would call a conveying resource first, with no need to send the car, but we'll be able to do that in the right, timely fashion. So it's going to incentivise more about getting the right resource to the patient, the right skills to the patient, rather than effectively a response and any response as the current standards lead us towards. As you can see on the right-hand side of that slide, it talks about less on-scene time for RRVs. Apologies for the technical jargon there. What that meant, RRV is a car, so Rapid Response Vehicle is what it stands for. And when it says less on-scene time, it's going back to what I was saying just now in terms of having the right resource and the right type of vehicle on scene. Less diverts, because we're taking the right patients to hospital that need to go and not the ones which don't. And as it says, less multi-vehicle deployments. Again, that's about making sure that we've got only one resource going to a particular patient that might need it at a point in time. Just going forward, I think I've covered most of these in just what I was saying about the ambulance response programme just generally, but again, it's, as it says, right clinical resource to meet the needs of the patient. When we think about the kind of quantity of individual vehicles, individual crew which go to a patient at the moment, you can see on the third bullet point there, it says that EMAS currently is 1.28 to REDS. That's EMAS across the whole of the regional patch. In Leicestershire, it's 1.5. So for every RED patient that we have, we send 1.5 resources, which obviously tells you that some patients have one resource, some have two, some have three and four. If you're in cardiac arrest, we send multiple vehicles from every single area that we can within the locality to get to that patient as quickly as possible, and that's our RED 1 category. As it says, the hear and treat and the see and treat is really critical in that the new response programme, because to really realise the benefits of the STP, care closer to home, making sure that patients are treated in their homes wherever it's possible, that again looks at the skill set of our frontline staff, it looks at the types of staff we have on our vehicles, and making sure that we're responding to those patients in the right way the first time. So moving forward then, this table on the screen now just articulates the different spread through the categories. So as it stands at the moment, the constitutional standards that we have are RED 1, RED 2, and a standard called A19, which looks at how quickly we get our conveying vehicle resource to scene. We have some local standards, which are Green 1, Green 2, Green 3, and Green 4. Going forward, the ambulance response programme will have 4 core categories, and they will all be constitutional standards, so categories 1, 2, 3 and 4, but they're not a direct mapping across of what we have at the moment with RED 1, RED 2, etc. So category 1 is still the most severe, so the most severely ill patients fall into category 1 going forward, but instead of it being 3 to 4% of our activity, as it currently is, it's looking likely that it's going to be around the 7 to 10% mark going forward. So more patients fall into the most serious category for the fastest possible response. Category 2, at the moment we fluctuate between 50 to 60% of our calls going into the RED 2 category, and as you can see on the screen there, category 2 we're estimating around 53%, so not too much change there. But that's really because some of the category 2 patients are going to now be category 1, and some of the category 3 patients are now going to be category 2. So actually category 2 stays very static, whereas actually more patients are going to get a faster response through category 1. I'm not a clinician by background, unfortunately, but I know Mark's probably itching to tell you what kind of patients those would be, which would have had a RED 2 response, which you now have a category 1 response, but I'm sure we can cover that in the questions if you wish. So there are elements of the ambulance response programme which we've already implemented and have had for a few months now in the East Midlands Ambulance Service. One of them is specifically around pre-alert triggers. Now, the flowchart on the screen there, although it's fairly self-explanatory, it's dramatically changed how we answer a 999 call. I hope none of you in the room have had the opportunity to ring our 999 control centre over the last couple of months, but if you have, for any reason, you would have been met with these particular questions. They're quite blunt, they're quite sharp and pointed, but that's because we're trying to get to the heart of the issue for the call as quickly as possible so we can get the right resource out, the right staff and the right vehicle to you. As you can see on the screen, some very key questions there. What we also couple this with is something called auto-dispatch. So when the call taker is working through these questions with you, if it meets the criteria in this flow chart where it ends up in the pre-alert category 1 box, the system that we use automatically looks at where all of our existing staff are around that particular location of the caller, and then will automatically allocate them to that particular call. So it's all done automatically rather than it's human intervention. Human intervention then assesses what the computer's done to make sure it's appropriate and adds extra resource on, but the initial phase of making sure that there's a particular vehicle which is going to be travelling to that patient is done automatically. So in terms of understanding what the ambulance response programme means to the patients of Leicestershire, what it means to EMAS as a trust and what it means to Tamsin, our commissioner, we've undertaken a piece of work, and we're still working through the findings of this, called the demand and capacity reviews, where we've worked with an external company, very specific work around looking at our historic way that we've delivered ambulance services around Leicestershire. But also looking at those new standards and then trying to see how they overlay into the model which we already run, where we've got some advantages of the new model and where there's things that we need to change to be able to make sure we meet the needs of the patients going forward. It's too early to say what those exact findings are in this particular forum, but as I said previously, as part of a future update on the ambulance response programme, I'm more than happy to give the committee a further update on that going forward. So finally, the last piece I wanted to just give you a quick update on was the CQC report. As you'll know, East Midlands Ambulance Service was inspected in November 2015, and that was a full CQC inspection at that time. We had a requires improvement from that CQC inspection and had a follow-up inspection in February this year, so February 2017. That report was published on the 13th of June. It's live on the CQC website. I recommend you have a look at it if you haven't done already. And that also gives us a requires improvement rating. What they have cited in the report, though, is that we've made significant improvements across a number of areas, and we've also managed to move our inadequate that we had for SAFE, the CQC SAFE domain, and that's now become a requires improvement. So there are no inadequates at all in our rating now. So just to give you the rundown of the 5 different CQC domains and how we sit. So safe, effective and well-led are requires improvement, and caring and responsive are both good. And that's our rating as it stands from the CQC. There is a quality summit tomorrow afternoon which is being held in Kegworth, which I understand invites have gone out for already. And that quality summit has been called by EMAS at the request of EMAS, and it's where all health and stakeholders are able to come together, where we discuss the report, seek support from our colleagues, but also give assurances around our plans going forward as well. And just finally, some of the achievements we're really proud of through that particular inspection are that we've been able to demonstrate that we've recruited more staff. We've been able to show that we've delivered improved outcomes for patients in Leicestershire and across the whole of the EMAS patch. We've invested in new vehicles and retired some old ones. And we've also implemented in the process of implementing our new electronic patient record system, which again, when we were talking earlier on in the committee about linking into existing care plans that patients might have, some of the ability for us to be able to really harness the ambulance response programme going forward comes from having access to the right information about that patient when we see them. If we can see that pertinent information, if we can see it live from the GP record, we can see the care plans for that patient, we can do the right thing for them there and then. And that's the end of my presentation. I'm happy to take any questions.
Okay, can I thank you first for your presentations, and before I just open up to questions, just a couple of, you talked about your staff retention levels, obviously from 10%, the attrition from 10% to 6%. I mean, are you fully staffed, fully resourced at the moment? Are there vacancies that aren't allowing you to complete your function?
So we're currently 10 to 15 staff shy at the moment, but we've got a run of staff that are coming into an education process. So whilst they're operationally short, they are in a plan and will be operationally available to us by October. September to October, they'll start to become operationally available to us.
And the second question was your, obviously the ambulance dispatch programme, which you've been awarded, part of the pilot programme you've been invited to. I think it would be good to get feedback on that from sort of this committee's point of view, so we'd welcome that. Within the categories 1 through to 4, you obviously talk about, say, 127 category 1s. Based on your multiple dispatches, you say you currently send 1.28 to say what's equivalent to a red. I mean, really simplistically, if you looked at categories 1 to 4 on a daily basis, that would tell you either how many vehicles or how many staff. Is that moving forward as part of this new programme? Is that achievable, or will it need more resource, or will it need less resource?
Okay, what I should have made clear, apologies, Chair, is that those figures which are included in that table are not Leicestershire only, that's a regional figure. So when you look at those number of calls, please bear that in mind. I think in terms of whether we have the right number of staff, whether we have the right number of vehicles to meet that demand going forward, that's something that the demand and capacity work is helping us work through. Because of the increase in availability of vehicle capacity that we'll have through some of the changes, that obviously is a plus. However, to counteract that, there's actually going to be more patients which need a faster response from us because there's more in the category 1 area. So I think it's too early to say exactly what the resource implications are looking like for it. Obviously more than happy to share that with the committee as soon as that work's been completed.
I think it was good to hear. I mean, the new accidents and emergencies obviously freeing up your ambulances, and that's making a difference as well. So that's good to hear. So, open it up to members. Dr. Hill.
Thank you. We've over the many years we've been here, EMAS has come in for a bit of stick from us in the past, but this is actually this is coming in, moving in the right direction now. I'm pleased that your staffing's getting together. About 18 months or so ago, a couple of myself and a couple of people from the previous committee went out individually and did a shift with the ambulance service, which was an extremely fascinating experience. And one of the things I got from that was you just hadn't got enough bodies on the ground. We were spent most of the time whizzing around, responding to things way, way away from where I'm based. It was very interesting. So I think that's good, and I'm pleased the response times are improving, because that's been a long-standing bone of contention for quite a long time, and that the CQC are sort of agreeing. So I'll be interested to see what the follow-up to this is. It's an interesting sounding piece of work, and I hope things continue to get better. Thank you, Chair.
Members. Councillor Richardson.
Sorry. You talk about the categories, and you have the fast response for the red or category 1. Can you just explain how it works for those that ring in that aren't classed as category 1, that could escalate to category 1 if they're waiting? Because sometimes people don't want to ring again because, they feel that they shouldn't be ringing 999 anyway. But I've been caught in that situation, so I'd just like to have clarification.
Yeah, thank you. I think it's important to note that the new ambulance response programme is designed to try and prevent escalation. So what we will be doing is, as part of the remodelling work for ARP, is reducing down the number of fast response cars we have and increasing the number of double crewed ambulances that we see out on the road. So that's how we're starting to enable a reduction in the number of resources we send to send to each incident. For those patients who do drop into the category 2 to 4, if you like, we have our clinical assessment team. So for those patients who may have been waiting for some time, the clinical assessment team will do welfare calls. So they will be actively ringing patients back, making sure that they're okay, making sure that everything's fine. Your smile tells me that wasn't or was the case. But what we're ideally trying to do is start to reduce the prolonged waits that patients have experienced through a range of different opportunities, so that we're not in a position where we're having to constantly welfare call patients.
I think that's a terrific idea. It didn't happen in my case, obviously. What sort of time limit do you give, for the welfare calls?
So typically, if a patient falls into a higher category of call, we would start to put welfare calls in after about 20 minutes if we were unable to attend the scene. If they were slightly lower down the categories, i.e. they were less urgent in terms of need, then they may be starting to do welfare calls within 30 to 45 minutes, and then there would be repeated welfare calls after that. As I say, the ideal is that we don't have welfare calls taking place, because that frees up our clinical assessment nurses. Excuse me, that's telling me I'm due on a conference call. What that does is it enables us to do more hear and treat, to take more calls out at source over the telephone, and enables our clinicians to do that rather than be welfare calling.
I'd really welcome that.
As would I, thank you.
Thank you. Councillor Taylor.
Thank you. If you can just explain a little bit more to you. You said obviously you want to reduce the multiple vehicles that attend an issue, but if it's a category 1, then it's an automatic sending of a vehicle. So probably most of category 1 is that are going to be conveyed to hospital, so obviously you want to be sending the ambulances there. But if there isn't an ambulance available, you will obviously be sending, is that an automatic rapid response vehicle that will then go? You'll then have to then call an ambulance. So I'm just interested to how the actual computer system that sends the automatic vehicles is going to try and cut down multiple vehicles attending a scene.
Okay, I think one of the things to bear in mind is, I'll come on to the system in a second, one of the things to bear in mind in particular is that the quantity of Category 1 calls that we have in Leicestershire at any moment or any particular day is quite small. Even at the 7% of our activity, it's quite a small number. But you're absolutely right. So the system has an algorithm in the back. So it knows what types of vehicles are in the system. It obviously knows where they all are. And it has an algorithm where it goes through effectively an ideal choice of vehicle to dispatch. And if that's not available, because there just aren't any within that particular vicinity, because it also calculates the amount of time on the roads it takes for the vehicle to get to that particular location in real time. So when it's trying to pick the vehicle, it doesn't just kind of draw a circle on a map and not take into account any of the roads. It actually understands how long it will take for each of those vehicles to get to the patient. So what it does is it runs through an algorithm which looks for the right type of vehicle first. If one of those isn't available within the required time to get to that patient, it then moves down to the next best, if you like, which in a Category 1 scenario at the ambulance response programme would be a car, because you're absolutely right, a double crewed ambulance conveying vehicle would be the ideal choice for a Category 1 patient, because you're absolutely right again, more than 99 times out of 100 that patient's going to be going to hospital because of the nature of their condition.
Can I? Sorry, just in addition to that, and Will's absolutely right. From a clinician's perspective, our Category 1 patients typically will be our most critically unwell patients. So patients could be peri or in cardiac arrest, and that's where we need the additional hands. So that's why we focus sometimes our fast response vehicles and put multiple resources onto those calls, because it's clinically appropriate to put more hands on to the patient and get a better patient outcome. And again, the ambulance response program is designed around clinical outcomes and getting the best clinical outcome for the patient. So that's just to give it a bit of a clinical slant as well.
So are you more likely to keep a patient waiting if they're in a Category 2 till 4 rather than send a multiple vehicle to that call?
No. So in every sense, our resourcing will be targeted. So as it sounds. A Category 1 would take the highest priority, 2, 3 and 4. What we'd look to do is utilise the time available to get to those patients in an appropriate manner. At the moment, what we're trying to do is send, so if, as Will touched on earlier on, yes, we have 3% Red 1 calls. We have, on average in Leicestershire, about 55% of our calls are Red 2. So we range between 50 to 60% of red calls, and we're at this time we're targeting our fast response vehicles to those calls as well as double crewed ambulances, because it's about achieving a standard. What the ambulance response programme does is it reduces down the number of calls we'll send our solo response cars to based on clinical appropriateness, and then allow us to use the additional resources that we've got free to cater for the rest of the patients. So as a rough snapshot, the reduction in resources per incident that we will see from the Red 2 categories, because we're not sending fast response cars and double crewed ambulances to them, will amount to somewhere between 5 and 8 double crewed ambulance hours extra shifts available every day. And that's an awful lot of resource. If somebody came and offered me it today, it would significantly assist. And again, it's just about getting to the patient quicker before they hit a point of deterioration.
Thank you. Councillor Parton.
Thank you. Before I ask these questions, I would obviously, like to give my complete and utter praise for all the ambulance staff that I've had contact with and the experiences I've known. So, because one or two of the questions that I've got would suggest otherwise, but it's completely not the case. Okay. I'd like to talk about mental health, if I may. So, in terms of when you receive a call about an overdose, what category is that put in? Because obviously, when a patient is distressed, it's very sometimes difficult to ascertain exactly how many tablets they've taken.
So it would depend on their clinical condition. So it would be very difficult, because they could fall into currently a Red 1 or a Green 4, depending on what the patient was presenting with. If they were unconscious, they could be in a Red 1 category. If they were distressed, they might be in a Green 1 to Green 2 category. So it really depends on the information that's passed to us over the phone at the time. I think what's probably, and it may well answer some of your further questions, is what's really important then is the response that patient receives. So regardless of the category, sometimes it's more important to the response that they receive. So working with the commissioners, we're currently doing some work around a mental health triage car, and trying to source a sustainable solution to how we can tend and treat the needs of mental health patients. And that's really about working with our mental health provider within Leicestershire and Rutland, which is LPT, to not just send a resource, which can be sometimes a blunt instrument, but sending the right resource, as we've been hearing earlier on from Will, so that the right person's on there to deliver the right care in the right place, or signpost to the right place. We have trialled this in other areas, and it's been hugely successful and beneficial, not just in terms of the destination for the patient, but for the outcome for the patient and the patient experience as well.
Yes, and of course, you see, leading on from that, where a patient says that they are suicidal, often it's the experience that patients are referred to the crisis team. Now, from the 999 call to the referral to the crisis team, do you link up with them for a response time that they will be in touch with them? Because obviously that they could be left alone for a period of time waiting for the crisis team to call.
So Tamsin may want to comment and follow up, or may not, but I think what we're saying with the mental health triage car, we're trying to take, in essence, the crisis team to the patient. So that we have a paramedic and a mental health professional working on a resource, and we respond to the patient appropriately. Where we are unable to do that, certainly out of hours, the crisis response team are based at the Leicester Royal Infirmary within the A&E department. So it's not necessarily in terms of a response time for the crisis team, but we're actually taking the patient then to the crisis team.
Oh, okay, right. The next two questions are quick, but unfortunately they wouldn't be questions that I would ask, but they're questions that I've been asked to ask by several of my sort of constituents. Are there times of the day where, if you were to plot a graph of your response times where it's maybe been you've received a complaint from the household or the patient when you've got there, or subsequently received a complaint, are there times of the day where you find it more problematic to adhere to your target, and there are times when you're not able to?
Okay, I'll start and then anybody else can follow up. So we typically know our demand curve across the course of the day. So typically our demand starts to increase about 7 o'clock in the morning. It peaks at midday, 12 o'clock. That's sustained through until about 2 o'clock, and then it starts to dip a little bit upwards towards, let's say, 5, 6 o'clock in the evening, and then we have another spike which is sustained on a slightly reducing scale through to about 11 o'clock, and then activity really reduces over the course of the next few hours through to that 7 o'clock spike in the morning again. Okay. And we can plot that. We can plot that by day, by month, by week, whichever we want. What we've started to do to try and meet some of the demand that we are facing, and it's difficult to say, is there an hour of the day where we receive more complaints than others? Typically we receive more compliments than we do complaints, and I think that's important to say.
I would agree.
But yes, it would be difficult to plot all of the complaints to say these are the key hours. We recognise from a service provision perspective that's at certain points of the day, and especially dependent on external factors like how busy primary care might be, how busy Leicester Royal Infirmary might be, impacts further upon our ability to respond to patients. What we've started to do is resource by forecast, which I mentioned earlier on. So we can use 5 years worth of historic data to model what we think our data is going to be for the next 12 months. What that allows us then to do is start to put the right resource out for the forecasted demand. And Will correct me if I'm wrong, but I'm led to believe that's about 95% accurate in terms of our forecast. So it's very good. So we are starting to try and meet the demand. But as I say, the forecast is only as good as a flat activity. When we start to see some of those external pressures or heat that starts to impact us, weather is a significant contributor to some of the challenges we face. That's where we would struggle.
If I may, just add a bit to that. Historically, what we've found in Leicestershire is that towards the back end of the day, handover times at Leicester Royal Infirmary get quite long as well, and that's a factor that obviously EMAS can't model for. They can't model what their handover time will be or how difficult it's going to be within Leicester Royal Infirmary. So we talked earlier about how that handover process is now much better and shorter, and that is leading to more reliability in your forecasting. So I think it's a combination of two things really, resourcing on forecast and making sure that consistently the handover times of the Royal Infirmary aren't taking capacity out, and that should reduce the poor patient experience related to long waits, particularly into the evening.
Yeah. I'll leave it at there, Chair. Thank you very much indeed. Thank you.
Thank you for that. I'm aware at the time we've obviously got 2 more items to deal with on the agenda. Could I just ask your algorithm that you use, does it include the air ambulance? Is that flagged up as part of an issue when that's called in?
Yes, that's right. I mean, the air ambulance effectively acts like any other resource that we have available to us. Clearly, there's certain criteria which the air ambulance will be deployed under and others where it won't. So, yeah, it's part of our normal resourcing.
Thank you. If there's no more... Sorry, Dr Hill.
Just quickly, you talked about a mental health triage card. I think it's a great idea. The police are already running one with LPT, so I hope you coordinate in some way with that, because you've got two emergency services running something with the same name. It's going to confuse people potentially.
Yeah, just to give you the assurance that we're talking to the police, they're part of an integral part of the conversation. It would be a multi-agency service anyway, so yeah, absolutely.
All right, in that case, can I thank you both? Can I thank Will and Mark? I understand Tamsin's going to stay with us just for the next item, possibly. But yeah, can I thank you for your presentation? I think updates will be good. Hopefully it'll be less than a year before you come back and see us. But look forward to some good positive updates. And yeah, keep up the good work. Thank you. Moving on now to the next item, item 12 on the agenda, which is a further update on the staff training relating to discharge. And can I welcome Jill Staton, Head of Nursing Specialist Medicine at the UHL. So it's look forward to your item and report. Thank you.
Hello. As I've been introduced, my name's Jill Staton and I'm Head of Nursing, and I currently lead a project called Red to Green Days Bed Approach at UHL, and I've been involved with a number of staff looking at staff training as part of that work. This paper just really provides a further update to the report that UHL presented to the Leicestershire Health and Wellbeing Board back in March in response to the lived experience of hospital discharge report, which was produced following a survey that Healthwatch Leicestershire undertook with patients, staff and carers about experience of hospital discharge. Basically, the report recommended 5 key elements, and one of those was around training. And basically they said that there needed to be a consistent approach to staff training, and that there needs to be an element of multidisciplinary and multi-agency focus. So the current situation that we're in is that there's no system-wide training currently for hospital discharge across Leicester and Rutland. However, I do want to reassure you that discharge training does take place, but it's on an ad hoc basis across all the organisations. A multidisciplinary discharge training project group was established last year, and they've recommended a number of key recommendations, and the principal one is that all staff who have direct patient contact should have essential to role training, and that has been endorsed, and that is what will be carried forward. In the paper, we've alluded to new ways of working, and one of the key ways is the launch of a new integrated discharge team, and that will operate at the front door, so at the emergency department, at the Royal Infirmary, right through to the assessment units, and go to the back door, which are our inpatient wards. So we're focusing on specialist medicine, orthopaedics and oncology, where the numbers of our patients with the most complex discharge needs are normally inpatients. The team's going to be composed of health and social care staff, and what it will mean in essence is that every morning every ward will have a member of that team on their board rounds where they review all patients in hospital, and so there'll be somebody there that'll be able to coach in a timely manner the staff on those wards and make the right decisions around discharge for patients, and that will take in the principles of Home First, which we heard earlier. Within that new team, there's going to be a specific role for leading and coordinating and delivering discharge training, and they're going to plan with our health and social care partners a programme that meets the needs that were identified in the original report. And what is envisaged is that all staff will have a competency-based passport which will endorse their knowledge and skills of the discharge pathways. We've heard today that we're on a journey of change, and clearly that staff are our biggest interface with our patients, and so they need to keep up to date with all the discharge training, and so we feel this is really important aspect of this journey. So training isn't going to go away, so I just really wanted you to sort of appreciate the amount of work that's been taken to improve the discharge pathway for the patients. Don't know if you've got any questions.
Councillor Gamble.
Thank you. Do you keep records of from when a patient has been told they can be discharged, an inpatient, to the time they're actually discharged?
Yes.
But for instance, I was an inpatient at the Royal last year. I was told I could go. I'd never been in hospital in my life. No one told me what I had to do. I had to sit for 3.5 hours on the bed waiting for a piece of paper to say I can go.
Yeah.
Obviously, that is a dreadful waste of time.
It is. So part of the work that I'm currently doing, called the Red to Green Days, but it looks at those internal and external weights. So we monitor patients that are told that they can go home, and we're looking at all the different steps in that journey. And one of the biggest steps you allude to is discharge medication, and that's about the doctors actually writing that discharge medication, so pharmacy can actually prescribe it. So we're working with our colleagues internally on that. The big ethos behind it all is that the patient's time is the biggest currency in healthcare, and we know that if you're 79 and a male and 83 and a female, if you come into hospital you have 1,000 days left on average to live in your life. And so it's about how would you want to spend those last 1,000 days. So we're doing a lot of work to cut down on that internal and external discharge.
I think we're all depressed now. So, Dr. Hill. Yeah.
So I'll tell my dad tonight he's got 1,000 days left. It'll really cheer him up. A couple of things. I mean, as a rule of thumb, people are going to the LRI, if they're going to be discharged, I reckon it'll be 2 o'clock till you get your meds, because it's a notorious issue that's people will be familiar with. But I was going to contrast 2 experiences of residents of mine in the recent past. One who waited 11 hours, and most of that was in the discharge lounge, and ended up getting readmitted and ended up staying as an inpatient for a few x-rays because the diabetes was out of control. So that's where it failed abysmally, and that was with meds, and then to do with getting a Riva car, and that was just a complete failure. And then another friend of mine whose mother was admitted, and she was discharged in 30 minutes flat, because she's so disruptive, because she's got quite severe dementia. They wanted her out of the ward. So it can be done. It's just a case of motivation. And if your little old lady is going to sit quietly and say nothing, you get ignored. If you're screaming and attacking the staff, you get kicked out pretty quickly. Now, I welcome the training, because this has been a perennial problem, and I hope it makes a difference. But everybody should be at the 30 minutes end and not at the 11 hours. Thank you, Chair.
Yeah, and I perfectly agree with that. And so we're working with staff in a number of different ways. So there's those patients that we know today that will go home tomorrow. So the idea is that they have all their medications planned the day before, and we monitor our wards in terms of metrics, how they're doing in regards to TTOs being prescribed the day before. So we're on that journey. We've been doing it 6 months now, and we have seen a decrease in our internal delays and external, and it's about that partnership working that we've got with our external and internal colleagues.
Okay, thank you. Councillor Richardson.
Thank you. Will this team be responsible for linking with example light bulb, etc., for helping assist people who need things happening in their home before they can be discharged? And also, I think the transport issue is quite a big thing with a number of people I've heard coming out of hospital. They're discharged, but the wait they have, they could be waiting till 8 at night to be taken home. You know, so that's an area I think that I'd like to know was included.
Do you want to ask to the IDT one first?
Yeah, go on, you can do that one.
So the integrated discharge team will absolutely be responsible for liaising with social care and discharge support services. So although they're quite a small hospital-based team, they're made up of representatives of all of the agencies that then facilitate support on discharge. So yes is the short answer to that. In terms of transport, we've absolutely recognised that the interface between UHL's discharge process and transport with the Arriva service has been really problematic over the last several years. And I think there's 2 facets to improving that, really. One is we have gone out to re-procure that service. So in October of this year, we will be changing transport provider. And one of the things we were really mindful of when we were selecting that provider is seeking to change the way that we describe the service, to take away some of the kind of contractual reasons why it was difficult for Arriva to meet discharge needs. But fundamentally, I think the problem's all about relationships and liaison, and that's why it's so critical that the work that Jill is doing to reduce some of the internal delays happens and improve the pre-planning for discharge and the reliability of that process, because what has happened typically is that a lot of discharges happen later in the day and the transport provider gets overloaded and then can't field enough crews to take people home, leading to the readmission scenario that Dr. Hill mentioned, and that's absolutely unacceptable from a patient experience perspective, and it's not good use of your beds because you're usually really desperate for beds as well. So collectively we want to avoid that. So with the new provider coming in, we've already started that discussion. It is dependent on the success of the red to green work, but it's also dependent on joint planning between the transport provider and UHL.
Okay, thank you. Councillor Taylor.
Thank you. I'd just like a bit more information about people that are well enough to leave hospital but not well enough to go home, and the relationship between respite care and residential care homes, because that seems to bed block for not hours but for days sometimes, waiting to assess, you know, what care home patients can go to and what support they need. So is there something to try and speed that up a little bit more?
So these patients will be picked up on the morning board rounds by this integrated discharge team. And since we've started work without the integrated discharge team over the last 6 months, we've seen a decrease in the number of patients that are waiting. We've established a weekly meeting with our external partners where we look at the patients that are waiting the longest in our beds to look creatively if can we do anything different. And I think over the last 6 months I feel definitely we have seen a success in decreasing that length of stay. We review our length of stay of patients who are delayed, who their next step is outside of UHL, and that has fallen in the last 6 months. And today, my figures show that we've got 8% of our patients that have been in hospital just over 20 days. The longest patient was 75 days and they're going home today. But when we've looked, we break down patients' journeys of what the actual delays were, and it was a minuscule amount, the actual time they were waiting for their ongoing packages. So I think the work we're doing is actually shortening that delay.
Thank you. Councillor Parton.
In terms of the for the third time, but it's very good feedback here, where it says on page 52, bullet point 9, new ways of working. But you take the time, and I'm very grateful for this. Thank you very much. You actually take the time to specify what they are. And I know in previous items on the agenda, some of them have been vague for various reasons, and there are explanations for that, as we've heard, but you've taken the time to actually specify them, so thank you very much. If I could just ask one question, which is relates to point 5 on 52, where it says these recommendations were presented to the UHL Emergency Quality Care Steering Group in April 2017, where the recommendations were agreed in principle. So where they've been agreed in principle, does that mean that there was some resistance or something needs to happen for that to move from in principle to actually action now occurring to actually implement them?
Yes, so basically that group, they agreed to the recommendations that staff training should be essential to role, and they recognised that we needed somebody to do it. So part of this integrated discharge team, there will be a key identified person to take on that role.
I think it's probably fair to say as well that it's a real struggle for UHL to prioritise training for staff amongst lots of other calls on their time and different elements of training that they have, including, you know, the mandatory training that they all have to have. And so I think that was one of the issues you had to work through, how you could really enable all staff to take up the training, and that's something you've been working through, isn't it?
Okay, thank you for that. I think that's an informative report. The recommendation at 16 is the Health and Overview and Scrutiny Committee are invited to receive the report and note the actions the Trust and our partners are undertaking to improve the discharge pathway to our patients, and the Trust plans to introduce the integrated discharge team on the 1st of July 2017, with a specific lead for staff training on discharge. I'd say that is the recommendation, so if members are happy, we'll note that. But I think obviously invite you back at some point just to tell us how your 1st of July implementation went, and if it's seen those times being reduced. So, cause obviously you've heard around the table specific examples where that's happened, and yeah, it'd be good to see that.
Yes, I'm happy to do that.
Okay, thank you.
Thank you
For your time. They would say save the best till last. Item 14, Sustainability and Transformation Plan. Toby, Managing Director of West Leicestershire Clinical Commissioning Group and lead for Leicestershire and Rutland STP, is going to provide us with an update. So I apologise that you've had to wait so long, but hopefully it's been interesting to listen to. And welcome, Toby.
Good afternoon, thank you. I'm really conscious that you've all been sat here for nudging 2 hours in what is a very warm room, and probably several of you may even be calculating how much we're eating into your remaining days, so apologies for that. My name's Toby Sanders. I'm the Managing Director of West Leicestershire Commissioning Group. I'm also the STP lead for Leicestershire and Rutland. I'm actually really deliberately sat and just listened to the last couple of hours worth of discussion, because I'm kind of tempted to say that actually the STP process across LLR is kind of all of the above. Every topic that we just walked through in this afternoon's discussion is part of what we're doing across Leicestershire and Rutland in terms of the sustainability and transformation partnership agenda that we have. What I've got for you is just a bit of a brief update. I'm conscious actually there's a number of new people around the table as well that I haven't had the pleasure either to meet or to speak to in previous discussions we've had here in Scrutiny on the STP agenda. So I'll try and keep this as brief as I can in order to have as much time as possible to ask any questions and answer as much as we might want to. So yeah, that's moving behind me. Cheryl Davenport earlier on very helpfully gave a bit of an overview of the Sustainability and Transformation Partnership the focus on producing plans across the country that both improve health outcomes, improve care and quality, and improve use of resources. And that's the core focus of what we've been doing across Leicestershire and Rutland over the last 18 months or so as part of the STP process. We published a draft plan in November of last year. Many of you may have seen sight of. It's on, I think someone made reference to the Better Care Together website earlier on. It's on that website, along with 43 other parts of the country who all published plans at roughly the same time. It is a draft plan, it's a draft document, and when we put that into the public domain, we committed to run a number of engagement events, a number of exercises over the last few months to gauge both public but also staff and partner reaction and feedback to that, and that's absolutely what we've been doing. So between November and May this year, just running up to the election, we ran a whole series of engagement events, around 10 sort of formal big public meetings, but also a whole host of other exercises of going out to meet with groups and talk to local areas. We ran about 10 large events with about 650 people that dropped into those over that couple of month period. We also, through that period as well, have talked extensively to staff in Leicester Partnership Trust, in UHL, local authority colleagues and elsewhere to gauge their reactions to some of the proposals set out within that draft plan. And crucially, during that period as well, whilst we're busy talking to folk locally, we've had a number of things, as they always do, which have moved on a bit nationally. So we have had an updated, something called Next Steps, which is NHS England's national update on the NHS 5-year forward view, which came out in March. Entirely backs and supports the continuing development of STP working, but also, as always, sets out a number of new areas and priorities for that work. So, in terms of what we've heard during that period, we've been collating the feedback and intelligence from that whole range of different conversations, and a number of things have come through really strongly. Just to canter through a few of those key messages. Quite strong, broad support, actually. Apologies for using the in principle word. We were talking about in principle just now. In principle, for the kind of direction for health and social care service development over Leicestershire and Rutland set out within that plan, particularly the key elements around Home First, around integrated locality team working that we've heard more about already this afternoon, about strengthening primary care, about community services. So, in principle, when you sit down and have conversations with members of the public, as I have done on many occasions over that period, a lot of, yeah, that kind of makes sense. That's sort of the kind of thing we'd expect you to be getting on with. But, and the big but here, is a lot of issues and concerns and questions, very understandably, about whether this can be done safely, particularly some of the originally proposed changes around inpatient acute hospital beds on the UHL sites. but also about whether it can be done safely within the funding envelope we've got, within the workforce challenges we have. We talked about general practice earlier on, one of those most critical areas in terms of workforce challenges, but also in terms of the resilience of adult social care as well, to be able to support some of those changes. A number of other themes and issues that are captured within this. We have put together a report which summarises all the feedback we've had from those events. It was received in public in my own commissioning group last week. It will be going on Thursday of this week to that system leadership team that was referred to, SLT, and one of those diagrams on the screen earlier on. That's a group that I chair that brings together the chief execs and the clinical or medical leads from across all the partner organisations. So John Sinnett's part of that group, as our equivalents from Leicester Hospital, LPT and so on. So we'll be looking and taking stock on Thursday this week of all of the feedback we've collated through those various discussions. But, crucially, we haven't, over that last 6-month period, just been sat still, leaving a draft plan on the side, having a conversation with people about whether they do or don't like elements within it. There's an awful lot of stuff we've just been getting on with. And you've heard a lot about some of those key areas of work this afternoon already. Crucially, though, if you look at the last 6 months, the NHS side of our system locally has delivered on a number of critical things. This is all about keeping the show on the road. We have delivered on our collective financial positions, and that's despite a hugely challenging public sector funding climate that you'll be only too familiar with from a local authority perspective, but certainly isn't getting any easier for any of us. But we managed to land where we needed to at the end of March. We've also, through all of that, and we often focus when we talk about STPs on the things that are in the future, the things that are 3, 4, 5 years down the line. We don't perhaps talk often enough about the improvements that our partnership is delivering locally, day in, day out. And again, you've heard a bit of some of these things already this afternoon. So we have delivered significant improvements locally around our sepsis pathway, particularly around the A&E department within Leicester Royal Infirmary, around hospital-acquired infections across LPT and across UHL, which have seen year-on-year sustained improvements over the last few years. Dramatic reduction in out-of-area placements for mental health patients who we don't or didn't previously have bed capacity for them within Leicestershire, and people were often being placed at some significant distance around other parts of the country. So a number of areas where we have made real progress over the last 6 months, as well as getting on and cracking on with some of the service improvement work that we've just been implementing as part of our day-to-day work. And again, you've heard a bit today about developments in things like the NHS 111 service, which has helped to get us to a place locally where we have one of the lowest levels of ambulance dispatch in response to calls to the NHS 111 number. And that's largely because we've increased a lot the number of doctors and nurses working within that service. Also, you've heard about things like the ED department and locality teams. So there's a lot of things the last 6 months that we've just been cracking on with. But at the same time as that, we have been using the last 6 months to refine and refresh elements of our plans in response to that feedback. That includes developing the detail around some of the workstream areas within our overall STP plan. It also includes making the case, and Sarah, you asked a question earlier on about capital funding. It's included making a case, continuing to make the case for capital investment, both in our acute hospitals infrastructure, but also in aspects of our mental health and community hospitals infrastructure. So we have this year in 17-18 submitted 3 applications, 3 bids into a national funding pot, which is about 325 million nationally. We expect to get an answer on that next month. Many of us have our fingers crossed. We'll find out. We have no indication at this stage. But that relates to investments in Hinckley Community Hospitals. It relates to investment in CAM services at Colville, or rather to re-provide some of those inpatient services from Colville back in the city. And it relates to investments in ITU services, intensive services at Leicester Hospitals. So we've submitted a number of in-year capital bids as part of that process. And we are also continuing to work on the overall infrastructure investment, both for IT infrastructure and for capital infrastructure, which we'll be submitting as part of the autumn processes that have been signalled by government in terms of the likelihood of quite substantial further Treasury investment during the course of this year. So we've definitely not been stood still over the last 6 months. We have been talking to people. We have been listening and reflecting. We've also been refreshing our plan. It was a draft plan we put out before Christmas. I've given a personal public commitment that we will, during the course of this summer, publish a final version of that plan. That's likely to be towards the back end of the summer, but we're absolutely on track to do that. That plan will look different in a number of areas, and just to give you a sense of the kind of things that I expect it to feel and look a bit different, there will be a greater and more explicit focus on prevention and early intervention. We've been working both with Mike from a county perspective and Ruth Tennant and Stephen Forbes from the city on this. It will have a greater focus on getting the basics right today rather than just designing and planning for a better future 4 or 5 years down the line, which often feels like we never quite get there. And it will crucially have a couple of other areas that I think people will read and feel are much more realistic and pragmatic, both on acute hospital beds, where the forecast and modelled reductions in acute bed base have been quite significantly moderated down as we've gone through that process of sense-checking some of those assumptions, and around workforce, where again I know with that draft plan pre-Christmas there was some anxiety understandably about the suggestion that we might end up with a smaller workforce at the end of that 5-year plan period. And actually, if you just look at it from a common sense point of view, if our budgets go up and our biggest source of expenditure is staff, it's almost inevitable we will have more people working in the system in 5 years' time. So very finally, we've also been using this period to look at how we strengthen our arrangements to deliver on the things that are set out within that draft plan. And in particular, that's evolving from STPs being seen very much as a plan, a thing, a document, as something to point at, into really what it's essentially about, which is a partnership. It's a group of organisations coming together across a place, and people like me in my kind of role, making sure that as a system we've got pieces of work underway to tackle the things that we know are most important for patients and for our population. And that's what's actually quite heartening today to have sat there listening to some of those different topics that have gone through, because they're all examples of where we've looked at it collectively and said we need to do something better for patients in those areas. We've put people, we've put clinicians, we've put managers onto those pieces of work, and we're starting to see things moving in those areas. So that's very much the gist of what this is about. But there are also some further things we need to do, and we'll be spending a chunk of time this Thursday in our system leadership team meeting looking at how we take out some of the other barriers that get in the way. And I think there is a different appetite nationally from NHS England, NHS Improvement and some of the other regulators to see local organisations working in a much more blurred way, if I describe it as that, with a much less absolute view between commissioners and providers, and much more of a we're all working together for the same group of patients in our area. We've got one pot of money, it's the LLR pound for the NHS. We need to make sure we make best use of that. So happy to take questions or any comments or thoughts. Thank you, Chair.
I think that was a really concise update and overview, so thank you for that. And yeah, it was interesting that some of the things you spoke about we have already had in the overview before this meeting started for members, and obviously throughout this meeting as well. So questions from members? No? No questions to be asked. I think it would be welcome to get the refresh plan when it comes back, whether it'll come through Mike sort of in your role, and whether it'll come back with sort of an overview from yourselves. I presume it'll be a massive document, so it's maybe too big for this committee, but certainly it'd be good to see what the refresh is. So
I'm hoping, Chair, it will be briefer than the original document by some way, so it will be less weighty than the first version. And actually, the gentleman to my right asked a question earlier on about engagement events that Cheryl mentioned that I would answer. We haven't got further events set up at the moment. We did that as a particular block, but we absolutely have committed that once we've got to a final version of that plan during the summer, we'll be running another series of events, and we'll make sure those are very widely published and well known.
Thank you, Chair. Yeah, just to say, I'm looking towards you and Rosemary. I'd expect when the final plan's available, we do an all-member briefing and then follow up with the scrutiny paper. So, yeah.
Okay. No other questions? No? Toby, can I thank you for your report? So concise and to the point, and thank you. Apologies for the wait again. So, I was just going to thank our two sort of non-members, Mike and Rick, who've sat there all the way through, and see if there's anything they wanted to add to the meeting. So it's obviously expert minds, but no, it's so Rick's obviously left us now. So date of next meeting, agenda item 15. The next meeting of this committee is scheduled to take place on the 6th of September 2017 at 2 o'clock, so look forward to that. And item 16, there were no other items which I decided to take as urgent, so thank you for that. I did ask a question in the Chair's briefing on the pink paper that we'd had, which was the Health Watch report. I thought it was a very good read. It was very informative, and there were recommendations on that the Health and Overview and Scrutiny Committee is asked to note the findings from the visit. So I just thought it was a useful report, and I would have said that to Rick, so perhaps if we can pass that on.
May I just ask for clarification then? So you stated that the date of the next meeting is on the 6th of September this year, and it starts at 2 o'clock. Did the reason the meeting today started at 2:30 was because we had the hour-long briefing? So going forward, the meetings will be at 2.
I'm reliably informed that was the reason for a 2:30 start, but it will be 2 o'clock in future. So, okay. Can I thank all members and officers and safe journey home, and certainly to the speakers as well. Thank you.